Hello and welcome to the final module for infectious diseases assessment and management, where we will be taking all of the knowledge we've acquired in modules 1 to 3 and our systematic approach we developed in module 4 to apply to some high-yield patient cases that represent common bacterial infectious diseases presentations in the hospital setting. My name is Jackson Stewart. I'm an infectious diseases clinical pharmacy specialist, and during the cases, I encourage you to pause the video at certain points to try the case for yourself, and then we will walk through our systematic approach to the cases together, integrating our knowledge. If you are able to follow along through these cases and practice assessing and preparing antibiotic recommendations for the cases yourself, you will be well armed to approach novel cases you encounter on the wards. If you make it through the cases, I have some quick bonus material as well on some high-yield infectious diseases topics at the end. Let's get right into the first case. In real life, we are not presented cases like we are in school with a fully complete history and physical, blood work with all the relevant details included in the vignette. Instead, in real life, we often hear 1 to 2 sentences about a patient and then wonder how we can jump into the assessment and management process. Often we need to know more about the case first before we can begin our systematic process. So let's simulate that in these cases. Take the case you hear involving a 6-year-old male who was previously healthy, now with new right lower leg redness, swelling, and limited range of motion. The patient was started on vancomycin IV, and you, on the ID consult team, were engaged for antibiotic advice. So how would you begin to approach this case? What would you focus on? In Module 4, we created a systematic approach that we will apply here. Remember, what was the first and most important step of our assessment process? The most important question is, what is the diagnosis, and is the diagnosis even infectious? Based on the limited history we've been given, I can't really tell what the diagnosis is clearly, which looks like it has some features of a skin soft tissue infection like redness and swelling, but also maybe some joint involvement with limited range of motion. I simply don't have enough information yet. The question is, what information am I looking for? The medical chart sometimes can be populated with tons of data, much is irrelevant for my assessment I'm trying to make. The answer is I need information regarding the symptoms, signs, blood work, microbiology, and diagnostic imaging that would assist in the gestalt assessment of the most likely diagnoses, given the few most likely infections this is already suspected to be. To refine my search, I think about what kinds of features I'd expect with the several infections I'm already suspecting. First, if this was a cellulitis or SSTI, I'd expect redness, tenderness, swelling, but no range of motion issues unless the limitation is simply due to local stiffness from swelling. I'd expect no problems with weight bearing and nil imaging findings. Second, if this was septic bursitis, I'd expect involvement over an area with a relevant bursa. For septic arthritis, I'd expect similar findings as cellulitis, but also with range of motion problems, possibly pain, and a joint filled with an effusion, which may have been tapped already for fluid analysis. Lastly, this could be a bone infection where I'd expect inability to weight bear in addition to signs of septic arthritis, as well as imaging findings suggestive of bony destruction/lesions plus minus microabscesses. Knowing these features to look for helps me when I'm digging through the chart notes. After knowing what to look for, I gather some more details in each of these categories. An updated vignette could be a 6-year-old male previously healthy with right tibial tenderness, redness, swelling, and limitation of range of motion at the knee with recent inability to weight bear. The patient is febrile with a white count of 13.1, blood culture is negative. This occurred after a recent fall at a soccer practice. An MRI was performed already, which demonstrates an abscess on the right anterior tibia with some evidence of bony destruction. So although this case was vague and ambiguous to start with, now that we've gone digging for things that are necessary to determine step 1, what do we know we are treating? And is this even infectious? The answer is, of course, that this is osteomyelitis, particularly in a long bone in a pediatric patient, of course, which is infectious, which is corroborated by the collection of all the assessment points taken together. Osteomyelitis is, of course, a well-known bacterial infection. So now that we know that treatment is justified, what do we do next? Remember, step 2 is to determine our most anticipated pathogens most likely implicated in the infection and decide if we are able to obtain any microbiologic testing to help us determine culture-directed therapy. We've done this before. We need to consider all the possible pathogens that could be causing this problem and then refine that list to the most likely pathogens. If there are any hints in the case that can make one pathogen more likely than the others, we need to find it. And then secondly, we have to ask if there's any microtests that can be done to help us. To know these details, I need to know a bit about osteomyelitis and the most common pathogens implicated. Luckily, we've reviewed osteomyelitis and are aware of the most common pathogens by route, in this case through a traumatic fall during a soccer practice. We are also aware of the abscess on the tibia, which could be a way of getting some microtesting done. The possible pathogens include Staphylococcus aureus, MSSA or MRSA, and beta hemolytic streptococcus, which form most cases. Possible but less likely include gram-negative organisms like E. coli or Pseudomonas, but there are no special risk factors in this history to suggest these. Maybe we can ask a question or two about the circumstances and social history to the patient. Anaerobes can rarely cause osteomyelitis, but usually have specific risk factors as well. We know that other pathogen types do not commonly cause osteomyelitis. Knowing that Staph aureus is likely the culprit pathogen, how can then we tell if we need to treat MRSA or as MSSA? The answer is we have to go back into the chart or ask the patient more questions. Remember what features might make us treat MRSA empirically. So going back to ask more questions and look in the chart for some social history cues for some interesting pathogens and for MSSA and MRSA, we find out that the patient lives in Edmonton, Alberta, in the city, has no history of recurrent boils or folliculitis, has no known past MRSA infections, and for what it's worth, swabs negative in the nose and perineum for MRSA colonization. So what is our most likely pathogen? In this case, of course, it should be MSSA. So updated, we are really likely treating an MSSA osteomyelitis with right tibial abscess. We also discussed the opportunity to get sampling from this abscess via orthopedic surgery, although they mention it is too small to sample, so we are unlikely to drain it. This is a good example of a case where, because culture-directed therapy will be impossible, we should really think through our most likely pathogen in this case, which we've justified. So now that we think we know that this is Staph aureus, more specifically MSSA, what empiric antibiotics should we use? Remember, the team already started the patient on vancomycin, so anything we suggest otherwise will be a change in therapy. Ideally, we minimally tamper with antibiotic therapy to reduce error. We need to know what are all the antibiotic options active against MSSA, and then create a short list of antibiotics by spectrum. Luckily, we've memorized antibiotics that are active against MSSA through our truncated bacteriology schema and SPECTRA approach in earlier modules. Via BLVCR, we know that cloxacillin as well as amoxiclav and piptaz are active against MSSA. First-generation cephalosporins and carbapenems are also reliably active. Vancomycin and Dapto are certainly active, but also kill MRSA unnecessarily. Clindamycin is probably reliable. For FAN-PST, fluoroquinolones are probably active, but not used commonly for MSSA. TMPSMX, however, would be reliably active. Lastly, tetracyclines would also be reliable, whereas macrolides would not be. Narrowing by spectrum, first we can isolate to cloxacillin and the first-generation cephalosporins. To highlight some other options and compare via NESA, let's also throw in TMPSMX and tetracyclines, which would be active in this case. Now that we have a short list, let's compare using our systematic process to select a justifiable empiric antibiotic choice instead of choosing one randomly. For necessity, we've already established the need for antibiotics. For efficacy, we should check for head-to-head trials for these antibiotics for osteomyelitis. Finding no clinical outcome data, all should be seen as active against MSSA, with doxy and TMPSMX unreliably covering if this was actually streptococcal. For safety, TMPSMX should be considered quite broad spectrum comparatively. Beta-lactams would also be tolerated the best among our choices, although cloxacillin would burn on PIV administration. There are nil drug interactions we know of in this case or allergies. Lastly, for adherence, our beta-lactam options are more frequent dosing than TMPSMX or doxycycline. All have PO options except for cefazolin, but the question is, can we even use PO antibiotics for pediatric osteomyelitis? If you don't know, check. In summary, our recommendation taking all of the above would be to discontinue vancomycin at any levels if they were ordered, and start IV cefazolin while the patient's acutely ill, to step down to PO cephalexin once clinically improved and ready to discharge for a course of 4 weeks total with outpatient follow-up. Remember, your NESA summary and judgment may slightly differ from others, and that's okay, as long as you can defend your choice confidently. Wrapping up, we've achieved the 3 primary goals in this case of deciding whether antibiotics are needed and clarifying the specific diagnosis, making an educated hypothesis to the most likely pathogen using our knowledge of microbiology and the disease, and selected thoughtfully an antibiotic regimen considering spectra of activity and a systematic thought process. Other considerations we have not touched on, like dosing, can be easily found in tertiary references and are less impactful. Here, we've made the most positive patient impact. The key learning point in this case is to clarify initially ambiguous and vague presentations in order to choose the best treatment. For example, if we had inappropriately considered this an SSTI or septic arthritis, we would have treated differently. For academic sake, consider, what if this patient also had an overlying cellulitis? Or what if they had both septic arthritis and osteomyelitis in this case? How would that have changed our plan? In both of these scenarios, the treatment for osteomyelitis, since it's the more severe problem and involves the longest treatment course, would be prioritized, and treatment directed at osteomyelitis would also be more than effective for these other problems, likely both caused by the concomitant MSSA. Perhaps there might be the need for paracentesis of the fluid at the joint in septic arthritis. We need to think critically about patient-specific quirks in these cases and be able to adapt on our feet for customizing treatment. Now let's get into our second case, a 35-year-old male with no fixed address and injection drug use, admitted with fevers, chills, rigors, and a new murmur, found to have Staph aureus bacteremia in 2 out of 2 culture sets at 9 hours and 49 minutes. The team started Vanco and ordered an echocardiogram. Again, how do we approach a case in ID? Do we actually know the diagnosis here? Are there diagnoses we may be missing? Let's apply a systematic approach again with this case and see if we can ensure that we catch all the necessary details. The first step is always clarifying exactly what is going on. In this case, we clearly have a case of confirmed Staphylococcus aureus bacteremia, which is never a contaminant in the blood. However, I know from modules 1 and 3 that when I see Staph aureus in the blood that it behaves metastatically. That is, it can spread and cause infection in other sites of the body. I need to decide on the source, but as well as the sites of metastatic spread, if any. We have an echocardiogram pending and a new murmur, but that's not enough to diagnose endocarditis. Where should I go looking for problems to help guide our final treatment plan? I can't tell for sure from the history, but I suspect injection drug use to be the source. For spread, I know that Staph aureus often spreads to the heart, the bones and joints, and commonly forms septic emboli we need to look for in cases of endocarditis. But what should I look for specifically if I suspect these sites? For endocarditis, I'm looking for clinical features of endocarditis like the immunologic features and symptomatic features, but most importantly, I need to see the results of our echocardiogram. For bone and joint infection, I need to do a skin inspection looking for redness, warmth, tenderness around any skin site or joint, particularly the spine and axial skeleton, the most common sites seated. If I notice any new pains, we should consider getting imaging like an ultrasound or CT scan if needed. Septic emboli can affect multiple sites. For example, if there is an intra-abdominal emboli from left-sided endocarditis, I'd expect abdominal pain, but would let the clinical history guide our search. Similarly, for pulmonary septic emboli, I'd expect respiratory symptoms or new chest x-ray findings. If you're unfamiliar with these places to look, always review before you manage your actual patients. Knowing what I'm looking for, I go back into the chart looking for specific things, plus minus, interviewing the patient if needed and examining for more details. An updated history is a 35-year-old male with injection drug use, admitted with fevers, chills, rigors, a new murmur, found to have MRSA bacteremia specifically. The echocardiogram returns as significant for a 1 cm by 1 cm tricuspid valve vegetation. The patient also endorses new right shoulder pain. An ultrasound is ordered for that shoulder, which reveals a joint effusion. There's no spinal pain or abdominal pain, and the chest x-ray is normal with new respiratory symptoms. So what are we actually treating here, and can we set up the right treatment plan and duration? This would be clarified as MRSA native valve tricuspid valve endocarditis with likely right shoulder septic arthritis. Therefore, there are multiple infections at play at this single patient. We've done a decent job at finding them all and making sure we know exactly what we're treating. Now that we've clarified this, what do we do next? Usually in step 2, we'd anticipate our most likely pathogen or send microtesting. In this case, we are already aware of MRSA in the blood, and based on our knowledge of the organism, it's almost certainly the organism causing the tricuspid valve vegetation and new right shoulder pain. Therefore, we can move directly to selecting an empiric treatment. We need to revisit for ourselves what are the possible agents that we could use and which is the best empirically in this scenario. Moving through our mnemonics, we know that vancomycin, linezolid, and daptomycin all have great efficacy against MRSA. Clindamycin is not perfectly reliable, and rifampin is only used in synergy. From our other mnemonics, fluoroquinolones probably have activity but are uncommonly used for MRSA, but TMP-SMX as well as doxycycline both have great PO activity against MRSA. So narrowing by spectrum, we could isolate to compare vanco to linezolid or daptomycin plus doxycycline since it is less broad spectrum than TMP-SMX. A reminder for when we compare agents using NESA, start to think about how long therapy will be and if that will change your concern regarding adverse effects or practical administration problems. First, we've already established the need for antibiotics. Second, nil RCT data is available for comparing the IV antibiotics in a head-to-head fashion, nor the PO options. There's minimal data whatsoever to support the use of doxycycline PO for MRSA endocarditis. Although it was used in the POET RCT, there are specific inclusion criteria we probably don't meet. Check if needed. We expect good activity strictly against MRSA for all of our IV agents. Keep in mind we're also treating a right shoulder septic arthritis as well. For safety, vancomycin causes nephrotoxicity and daptomycin can seldom cause a rhabdomyolysis. With longer-term treatments, linezolid can cause some mitochondrial toxicities as we know. Doxycycline is probably the best tolerated amongst the options. And lastly, for adherence, we need to decide if we can use PO for endocarditis. Check if needed. Linezolid and daptomycin are typically restricted for VRE or MRSA where vancomycin is not an option. Therefore, vancomycin is a good summary recommendation for empiric and definitive treatment for a duration of 6 weeks total, the clock starting with first negative blood culture or from the date of the operation if a surgery occurs and the vegetation is culture positive for MRSA despite blood culture clearance. In this case, I would not trust PO treatment alone due to the extent of the metastatic infection involved in this case. In our case continued, we follow up with therapy on day 5 for planned monitoring while in hospital. On day 5, we noticed that blood cultures remain persistently positive in daily cultures since our initial assessment. The patient remains on vancomycin and there are no new signs of metastatic spread. No other treatment has been given, although a new PICC line has been placed for long-term IV therapy. So we have to answer, why is our patient not improving on vancomycin? Remembering Module 4, in cases like this, we must consider our common causes of apparent clinical failure. Most commonly, lack of appropriate source control. In our case, that vegetation in the tricuspid valve may require surgery in consult with our cardiac surgery colleagues, and if this is possible, could allow clearance of an important nidus. Additionally, the shoulder might be a new source, and fluid aspiration for removal of the infected fluid might assess as well. Importantly, a new PICC line was placed, which if patients are bacteremic during the time when a line is placed, it can become colonized and infected with Staphylococcus aureus that is in the blood. Removal and exchange of lines is unfortunately necessary in patients who are persistently bacteremic, and we should continue to follow daily blood cultures for clearance. Although dose too low could theoretically be a problem, we should rule out more common causes first in this case. Wrapping up, we have identified all the clinical problems associated with the Staph aureus bacteremia in this case, identifying the likely source and recognizing the sites of metastatic spread, which helped us create a final treatment recommendation that would manage all indications. However, the key in this case was recognizing the need for source control and making sure that the infected niduses were identified as a probable cause of persistent bacteremia despite effective antibiotics. In this case, we followed up with cardiac surgery who removed the vegetation, replaced IV lines and drained the shoulder. Blood cultures cleared afterwards. Revisit this case to review important management of Staphylococcus aureus bacteremia, an extremely common inpatient bacterial infectious diseases problem. In our third case, we have a 65-year-old female, previously from home, admitted with a cough and a fever. She is diagnosed with pneumonia by the ED attending and started on piperacillin and tazobactam. We've reviewed pneumonia a few times. What should we be asking here? What exactly is going on with our patient, and does she need antibiotics? Let's go through our systematic approach again. So far, what do we know about what is really going on? We know she has a cough and a fever, so respiratory infection is possible, but we have no clues to the specifics of the pneumonia. If this is actually infectious, what types of infection could this be, and what should I be looking for in the chart specifically? Of course, this could be viral or bacterial pneumonia, atypical pneumonia, aspiration, or even an acute exacerbation of COPD. Rarely, there are even some causes that could be non-viral and non-bacterial. First, this could be community-acquired pneumonia. I'd expect the patient to present differently if this was capped due to a typical bacteria like Streptococcus versus a viral or atypical pathogen. I'll look for these specifics in the chart. Next, it could be aspiration. I'd expect to see some compelling evidence that she is at risk of failing to protect her airway if this is the case. And it could be acute exacerbation of COPD, but of course, she would need either a diagnosis of COPD or appear to have undiagnosed COPD. Antibiotics are typically warranted in an acute exacerbation if there are 2 out of the 3 of increased sputum volume, increased purulence, and increased work of breathing. Lastly, this could be some dangerous and uncommon indication, and so it's good to be able to identify red flags. Like in this case, weight loss over months if it was present, an atypical course that has worsened over months, the patient being from certain geographic locations, or the patient being found to be profoundly immunocompromised. Knowing what to look for, we find out that this is a 65-year-old female from home with known COPD, admitted with a non-purulent cough, worsening shortness of breath and fever 39.3 for 7 days. She had sick contacts 3 weeks ago at work. Her white count is 12.5 without any history of choking or swallowing problems. Her chest x-ray is shown to the right, with right worse than left bilateral patchy opacities. Her sputum has not changed in quality, but her work of breathing has been worsening, leading her to come to the hospital. So what are we most likely treating? Do we still need our PIP, tazo, and antibiotics while we wait? In this case, this is most likely viral pneumonia, or less likely atypical pneumonia. Given the clinical milieu of sick contacts, a week-long acuity, plus worsening and bilateral chest x-ray findings, this of course should help us guide treatment and microtesting if needed. So what do we do next? We have to now anticipate the most likely pathogens and discuss opportunities for microtesting. Remember, we have microtesting options that can help us detect both bacteria, although often contaminated via the sputum in the mouth, and viruses via PCR or molecular testing. The most common pathogens should be seen as viruses, namely enterorhinovirus, influenza, parainfluenza, coronaviruses, RSV, metapneumovirus, and others. All are testable via an MP swab. Atypical bacteria are also possible, but less likely given the history and the 7-day onset. These are Mycoplasma, Legionella, and Chlamydia species. Mycoplasma can be detected via the same viral MP-PCR test, but the others require more specific tests. This has narrowed down our list, but we should confirm our suspicions with micro-testing recommendations so we can select the appropriate treatment. Updated, we've asked for a sputum culture for what it's worth, as well as an NP swab for a respiratory pathogen panel looking for viral nucleic acids, as well as a urinary Legionella antigen. Results become positive for COVID-19 nucleic acid. So in our case, what are we treating? Is this a co-infection with multiple pathogens? No, in this case we've got a coronavirus viral community-acquired pneumonia. Although many might have seen the piperacillin and tazobactam and simply attempted to step down to ceftriaxone plus azithromycin, a better thoughtful approach could lead us to the correct pathogen and avoid unnecessary antibiotic treatment, which can lead to harm. However, as a consultant or learner, you may find resistance when taking antibiotics off a patient like this. In the case continued, we recommend stopping antibiotics and receive a message from the MRP attending, which says, "Stop antibiotics. What if she has a secondary bacterial pneumonia?" So what would your answer be? If you're following along and agree so far, try answering for yourself, since you always need to be able to justify and defend your answers and actions in medicine. I might have built the case for this recommendation, but try defending it yourself if you agree. A good answer would be, it is reasonable to be concerned. Although our patient has no double sickening, so no new worsening, had a delayed presentation 7 days compatible with viral pneumonia, a nil impressive white count, a non-productive sputum, and a chest x-ray findings that are characteristic of viral pneumonia, non-lobar and bilateral findings, it is unlikely in this case that there is a secondary bacterial infection. But if the patient worsens in hospital or develops a new fever or chest x-ray findings while in hospital, antibiotics could be warranted for a hospital-acquired pneumonia. As the MRP, physicians must safeguard their patients, and although they often know that viral infections don't deserve antibiotics, it's sometimes hard to let go. Wrapping up case 3, we've identified correctly that antibiotics are not indicated in this case and did not have to proceed unnecessarily to discussing antibiotic choice, dose, or duration. The key in this case was not only identifying the virus, but being able to justify and defend the withholding of antibiotics from a sick patient and protecting them from the harms of unnecessary antibiotics. Remember, there are clues to differentiating viruses from bacterial infections or non-infections, but we always need to take all assessment pieces together to create a gestalt judgment and not rely on one factor more than the rest. In case 4, we have the report which states an 83-year-old female with dementia found down at home on the bathroom floor, incontinent of urine, delirious and ED, probable urinary tract infection. Started on Piptazo in the hospital and admitted. This is an extremely common inpatient presentation and case, so we should pay close attention to how we manage this. What should we be looking for in this type of case? Do we know the specific diagnosis? Sometimes when we read cases like this, we can already start to have biased opinions on what is actually going on. A challenge is to approach our data gathering in a non-biased way, not looking to confirm our suspicions, but to get to the bottom of what is really happening. We know that the attending service believes there is a UTI given the patient's delirium. In this case, what is our evidence of actual UTI? Here I don't see much in our vignette. That doesn't mean it's not present, it just means I haven't found it yet. I need to go looking and know what I'm looking for. Next, what are the causes of delirium? Yes, in cases where the chief complaint is blamed on an infection, we need to know other possible causes so we can see that if there are better explanations. Remember, a common mnemonic for delirium is equal to DIMS, which we can use to look for other causes. And in this female, we should be asking, if this is a UTI, is it a cystitis, a pyelonephritis, or a catheter-related UTI? Our DIMS mnemonic stands for drugs, i.e. polypharmacy, contributing to delirium, infection, which is possible, but you usually need other symptoms to confirm, metabolic, i.e. fluid, electrolyte, or nutritional problems, and structural, i.e. ischemia, central nervous system disease, hypoxia, or bleeding. If this was a pyelonephritis, despite trouble with history taking in someone with dementia, I'd still expect to see fever, chills, CVA tenderness or flank pain, and lower urinary tract symptoms. In patients who have trouble remembering things, they usually can still remember that it burns when they pee. Patients with pyelonephritis are usually quite ill, but we know that infections can look masked in our older adult population. If this was cystitis, I'd expect nil systemic features, probably no delirium at all. I'd expect lower urinary tract symptoms and suprapubic heaviness and tenderness. And lastly, if this was catheter associated, I'd expect that our patient was using an indwelling catheter at home in addition to the above features. In our case, UTI is a non-specific working diagnosis that we need to clarify. Knowing what to look for, we find that an updated vignette is our 83-year-old female found down at home on the bathroom floor, incontinent of urine, no known lower urinary tract symptoms prior, and started gabapentin and tramadol acetaminophen 1 week ago for back pain. The patient has been eating and drinking less than usual and has a sodium in hospital found to be 128. Her MMSE is 19, she's afebrile, has a normal white count with nil CVA tenderness or suprapubic tenderness. The urinalysis returns with pyuria and bacteriuria with a urine culture positive for 10 to the 6 colony-forming units of Enterococcus faecalis. I can't tell you how many times we see a case exactly like this in the hospital setting. So what's really going on? What would you call this? A reasonable answer is delirium with multiple contributors, unlikely infectious. In this case, we have multiple confounding problems which certainly could be causing delirium, i.e. hyponatremia, reduced intake, and polypharmacy. Despite the multiple other causes, does this rule out that there is also a UTI? What would your real-life approach be to this scenario? Let's practice that. What would you say to the attending MD if you were consulted on the case, or if you were the attending MRP, how would you approach this case to best treat your patient? It's okay to have slightly different answers than others, but be able to defend and justify your answer. Pause to try for yourself, creating a complete plan of approach. I'll give you my suggested approach to the case. I would say there seems to be multiple causes of delirium in this patient, including hyponatremia and clear polypharmacy issues. A positive urinalysis and culture in this context could be related to asymptomatic bacteriuria in the absence of any other features of UTI at all. Incontinence in this case might be functional due to dementia or otherwise. So my suggestion could be, let's treat the known causes of delirium first, hold off of antibiotics which could be harmful, and follow up clinically for signs of UTI. Sometimes the tincture of time is what is needed to determine the best action. Holding off of antibiotics in someone who is not actively sick can limit the harms of treatment and allow a patient to reveal the diagnosis, and that relies on us clinically observing our patients. For academic sake, let's consider what if this was an infection. We know we're growing Enterococcus in the urine. If this was an infection, it would probably be best described as a cystitis, since there are nil systemic features or CVA tenderness, despite delirium rarely being caused truly by a cystitis without other features. Again, this is for practice. Is Enterococcus a common urinary pathogen? What about its growth as 10 to the 6 colony-forming units? In this case, Enterococcus is present in scant amounts. Treating the most common cystitis organisms seems a better approach because it is likely this organism could be irrelevant. The most common organisms are, of course, the GI commensals like the Enterobacterialis, like E. coli, Klebsiella, and Proteus. Enterococcus might cause a true cystitis, but is certainly not the most common pathogen. Other organisms might cause uncomplicated cystitis in young females, irrelevant in this case. Although we don't think Enterococcus is likely the primary pathogen if this was infectious, let's see if we can't kill it anyway, along with the other gram-negative bacilli. Let's think of our antibiotic options which would kill our most likely pathogen groups are Enterobacterialis plus minus Enterococcus. Pause to practice this list yourself. Luckily in Module 2, we've memorized our antibiotic spectra so that we can list them out by mnemonics systematically. From BLVCR, we have amoxiclav, piptaz, ceftriaxone, and ceftazidime, although only the BLBLIs would also kill Enterococcus faecalis. Carbapenems could also, but would be much too broad here. From a FAN PST mnemonic, both nitrofurantoin and phosphomycin would cover both of our organisms, whereas fluoroquinolones, aminoglycosides, and TMPSMX are reliable only really for Enterobacterialis. Tigecycline could as well, of course, but again, much too broad. So narrowing first by spectrum, we could isolate to amoxiclav, phosphomycin, or nitrofurantoin, all of which would give us coverage against this Enterococcus if it was not simply an irrelevant contaminant. By practicing in this case, coming up with an antibiotic plan anyways, we are learning how to create contingency plans, such that if other providers refuse to stop antibiotics despite not needing them, we might be able to create a modified antibiotic plan that better protects our patient from antibiotic collateral damage. It's always best to think about protecting patients in this way. In this case continued, we suggested to stop antibiotics since this was unlikely an infection, and for academic sake, the team denied our suggestion, scared for an occult infection. So we then use our contingency plan and advocate for a one-dose only phosphomycin 3 grams PO sachet that would be very effective against common Enterobacterialis as well as Enterococcus faecalis if it was relevant at all in the urine. The team agrees to this, and we plan on clinically observing our patient afterwards, although we don't expect improvement since this was likely never an infection in the first place. In this case, we've practiced the most common actions important for infectious diseases management. We skipped over our NESA comparing those antibiotics. If you want some more practice in this case, try comparing those antibiotics for yourself and see if you agree with my final recommendation. Remember, if you are consulting or advising, we may not always be able to achieve our best outcome if there is disagreement between providers. Plan ahead for still trying to mitigate collateral damage of antibiotics. For our last case, we have a 42-year-old male, originally from India, who is admitted with E. coli bacteremia and history of ESBL-producing E. coli infections. He is started on ceftriaxone by the attending general internal medicine team who consult infectious diseases for advice. Notice in this vignette there may be details that are included that you're not sure of the relevance of. Example, telling you that the patient is from India. If you're not sure of the significance, don't skip over it. The more practice you get with learning the clinical relevance of details in stories like this, the better you'll become at screening out irrelevant details and cluing into important points that can be useful in changing antibiotic treatment. First, in this case, we have to ask what is actually going on here. What are the specific diagnoses that could be occurring? Let's apply our systematic approach once more. In this case, we know that for sure the patient has E. coli bacteremia. That is definitive from our microtest. But as with all bacteremia, I wonder, where is it coming from? Do they have another infection? Where would I expect E. coli to be coming from? Also, I noticed that the patient is from India, and I know from Module 1 that some places in India, for example New Delhi, and other parts of the world have higher rates of ESBL-producing Enterobacterialis. I wonder, however, how long has it been since the patient was in India? Are they colonized with local E. coli or E. coli from where they are from in India? Remember, we know E. coli is a GI organism, so I'm looking for possible GI or GU sources. If this patient has had any infections in Canada, we can often look them up as well as their past microbiology specimens. Looking for specific sources, I'm planning on looking for evidence of an intra-abdominal infection like cholecystitis or cholangitis hinted at by abdominal pain and fever. I could also look for signs and symptoms of a urinary tract infection. Importantly, however, we need to decide if this E. coli is likely going to be ESBL producing or not. My patient has a history of this, but I'm not sure of how remote. What are some features that might make me think this E. coli might not be drug resistant? Well, first, of course, if more recent cultures demonstrated a non-resistant strain. Even if the patient has historically resistant strains, we rely on more recent cultures predominantly to decide on the likelihood of current resistance. Second, if the patient has not visited an endemic resistant site for many years, it is more likely that the patient is colonized with local non-resistant E. coli. And lastly, if the patient acquired the E. coli from the community, this also reduces the chances of drug resistance, since we know that local drug-resistant gram-negatives are more frequently acquired in the hospital. The key point is here, if you are thinking of drug-resistant organisms, always check past cultures. This is the best way to assess. In our updated history, we discovered that the patient is a 42-year-old man born in India, but moved to Canada at age 10, who now has E. coli bacteremia. He has an ESBL positive infectious history, but this was from when he was 22, from a GI source. More recently, at the age of 40, which is 2 years ago, he had a cholecystitis complicated by E. coli bacteremia, although this E. coli was actually pan-sensitive, except for resistant to TMP-SMX. Now he presents with new right upper quadrant colicky pain, fever but no jaundice, and his ultrasound is demonstrative of an obstructive gallstone in the cystic duct. He has a leukocytosis, and as previous, his team had started ceftriaxone. So first things first, what are we treating exactly? In this case, you could summarize this as a cholecystitis complicated by an E. coli bacteremia. In this case, not likely due to an ESBL organism, given his more recent non-ESBL isolate. Although this patient has some risk factors for ESBL infections, by taking a closer look at past microbiology, we were able to determine that he most recently had non-resistant E. coli. Always review past culture data when assessing a patient with infectious diseases, since there's a wealth of useful information available that many people fail to look at. In this case, we know that the pathogen is E. coli, so we can move straight to empiric antibiotic choice. Normally, we'd wonder if we need to worry about empirically covering ESBL producing E. coli or not, but in this case, we've made the case that this is unlikely ESBL producing. We should always consider how confident we are in that assessment whenever selecting an antibiotic. For all agents that have activity against E. coli, we could consider amoxiclav, piptaz, or ceftriaxone, as well as carbapenems and estrianam. Our VCR mnemonic has nil activity. Our FAN-PST mnemonic activity has many agents available, although most are reserved, for example, fosfomycin IV, aminoglycosides, and colistin. In this case, fluoroquinolones could be a good choice, but they might be unreliable empirically. TMP-SMX is not always reliable, and in our patient's most recent isolate, it was resistant. The tigecycline is another choice that's usually reserved for drug resistance. So narrowing by spectrum and question of ESBL, we could look at ceftriaxone versus meropenem versus ciprofloxacin. Performing our NESA, we've established necessity. We should check for head-to-head data for E. coli bacteremia with these agents. There is some data looking at outcomes for ESBL producing E. coli. However, in this case, we don't strongly suspect ESBL E. coli for our reasons we've stated. Ceftriaxone and meropenem should be considered more reliable than ciprofloxacin in our case from an empiric perspective. For safety, carbapenems would be broader than needed, which is a safety concern. Ciprofloxacin has some rare adverse effects, none of which I'd be overly concerned about in a short course, so ceftriaxone could be considered the best tolerated. Lastly, for adherence, ceftriaxone is once a day versus multiple daily dosing in other agents. Importantly, you have to ask yourself, can we use PO for an E. coli bacteremia with cholecystitis? And if you don't know, you should always go and look and check if there's support for that strategy. Ultimately, my summary assessment would be to use ceftriaxone intravenously, despite this chart note of ESBL history, until susceptibilities are known, at which point we could step down to either Cipro or TMPSMX to finish a 7-day total course, unless there was some nidus development like a rupture or an abscess, which is unlikely in this case. Think to yourself additionally, if this patient had been critically ill and dying, would that change your confidence in using ceftriaxone instead of meropenem? Ultimately, we have to make a decision in judgment. If this was the only new detail in the case, critical illness itself does not increase the chance that our patient has ESBL-producing organisms, but it might increase the consequences and the chances of consequences if we're wrong. In cases where you can't be so certain, it is always reasonable to empirically and initially be slightly broader than needed, but only if you have a plan to revisit the case in 24 to 40 hours with more information and back off that broad spectrum antibiotic plan if you are able to. In our case, we suggest to continue ceftriaxone. Now we're going to practice setting up our monitoring parameters. So think to yourself, what are you going to deliberately and actually watch for on a daily basis with this therapy plan while the patient is in hospital? Do you need to watch for anything? Practice setting up a monitoring parameters for both efficacy and safety. Pause the video to see if your parameters and details match up with mine. Think as well, whenever you create monitoring plans, is there anything else medically that we're waiting for to make a final plan? For example, source control, imaging, or some other tests. In my monitoring plans, I have 3 factors every time. Efficacy, so monitoring for treatment and making sure it's going well. Safety, so monitoring that the antibiotics are tolerated. And something I call a waiting plan, so any details that we're waiting for in this case before we can set the final treatment plan and sign off. In our case, for efficacy, I check for the signs and symptoms that brought the patient to our attention in the first place. So in this case, right upper quadrant pain, fevers, chills, and making sure those have improved. I can also check for vitals as well as blood work like a white count. For safety, I know that ceftriaxone is very well tolerated, but might just monitor for GI symptoms or diarrhea to make sure the patient is not having C. diff. I would personally check on that daily. Lastly, I know that we are waiting for susceptibilities and for the patient to be able to take PO so that we can create our final antibiotic plan. So I should always check if we are able to do this daily. Whenever making a monitoring plan, be sure to specify who will be doing the monitoring specifically and how frequently. On the right, I've included a list of some barriers to IV to PO step down as well. Wrapping up, in this case we've correctly identified the full problem, initially only known to be an E. coli bacteremia, but now known to also represent cholecystitis, confirmed that this was likely to be non-ESBL producing E. coli, confirmed the best antibiotic option and plan, and selected a reasonable duration of therapy. Sometimes providers see antimicrobial stewardship as the compulsive effort to narrow antibiotic spectra of activity, but what antimicrobial stewardship really means is the judicious and appropriate best use of antibiotic agents. That means that in a patient who is being undertreated, we might actually broaden therapy if that is best. However, broadening therapy is hardly ever required. Since in the majority of cases, as you've seen in these modules, we can always be more specific about what is actually going on, which narrows our list of possible pathogens and therefore narrows the spectral requirement of our antibiotic choices. Importantly, when you hear vaguely about drug resistance histories in any patient, you should second guess it and see for yourself if it's actually likely that a patient will have a drug-resistant organism. Briefly, for the first bonus topic, I wanted to touch on febrile neutropenia, a common reason for antibiotic prescribing in the hospital. Febrile neutropenia is not a disease or an infection, but a syndrome, which literally means a patient with a fever who has neutropenia. The definition is a single fever over 38.3 and an ANC of less than 0.5, depending on the reference, but the hard definition is less important than the syndrome. Ultimately, it occurs in patients commonly with AML or MDS who are ill from their malignancy or post-chemotherapy, and rightfully in patients who develop a new fever for any reason, we should be thinking about infection. However, in these patients, infection may or may not be the cause of the fever. Frequently, no cause of the fever is identified, but similarly, fever is also eventually attributed to either malignancy as the active disease or chemotherapy and reactions to those drugs. Ultimately, patients deserve good care by investigation for sources of infection, i.e. a history, physical exam looking for common infections, a blood culture, and if any source of infection is actually suspected, further investigation. However, in the majority of patients, no locus of infection will be identified. So how can we best manage these patients' antibiotics? Initial antibiotic treatment after blood cultures is reasonable, narrowing based on the locus of infection. But if no locus of infection is identified and blood cultures are confirmed negative, we should reconsider the use of antibiotics. Consider stopping antibiotics, especially once fever subsides, but even before, if no evidence of infection is present, since they are simply prophylactic at this point and could be causing harm. The good thing about antibiotics in this setting is if we stop antibiotics after not finding an infection, we can always restart. Be judicious and preserve our options for these patients who might need them in the future. Antibiotic prophylaxis is the second quick bonus topic and refers to giving antibiotics for prevention purposes. That is, in a patient who is at high risk of developing an infection, giving antibiotics ahead of time in order to limit their risk. Although a bit complicated with many different specific indications, we'll briefly cover the fundamentals. By definition, a patient must have a high risk of infection to warrant prophylaxis, assuming that the antibiotics and not sterile technique or care are enough to prevent all infections. In this way, I actually see two distinct scenarios for antibiotic prophylaxis. Let's discuss the first scenario. A patient is going to have a temporary high-risk period where infection could occur, for example, during a surgery. Before their surgery, their risk of infection is low. During the surgery, when their skin is breached, and depending on the details of the invasiveness of the surgery, their risk is high, and then after surgery, their risk is low again. We would give an antibiotic ideally that kills bacteria that would be most likely to contaminate the skin, so for example, cefazolin for killing MSSA relating to skin dissection. In this patient, therefore, the ideal time to give antibiotics is before the surgery, since we'll get exposures that might protect them against MSSA that last during the surgery. However, there would be no need for antibiotics after surgery, since the patient's risk of infection has dissipated, especially in surgeries where there is closure. So the patient should only need one dose prior to the OR, plus minus another dose if the OR is very long. And this is where the problems are. Many surgical prophylaxis regimens contain prescriptions for antibiotics that continue post-op. This is simply not needed for the reasons stated, and this practice is luckily slowly coming out of favor. The only conceivable reason for post-op antibiotics would be if there is a good reason why infectious risk remains high, for example, in open abdomen or other dirty contaminated sites. However, if the sites are kept clean, for example, post-wisdom tooth extraction, there is negligible infectious risk compared to when the knife is actually breaking into the skin or membranes. The point is, we should decide deliberately if prophylaxis is warranted, for example, if infectious risk is actually remaining high in the scenario where a patient has a temporary risk of infection. Scenario 2 is different, where risk of infection is expected to be high for some prolonged period of time, possibly indefinitely. So a very different group of patients. Let's take the case of a patient, for example, with posterior urethral valves and recurrent UTIs. This patient gets about 5 urinary tract infections a year, and it's expected that this will keep occurring. Since the patient still has posterior urethral valves, which can trap urine in the lower tract and create nitises of infection, in this patient, urology orders nitrofurantoin prophylaxis to stop UTIs from occurring. In this patient, antibiotic prophylaxis is actually controversial. The question for you is, what do you think would happen? For example, if this patient was started on this prophylactic agent, would the patient just never get an infection ever again? The answer is, they will still get an infection again. It'll just be with a new or resistant bacteria. That is the problem with long-term prophylaxis for diseases which require source control or some other intervention but are not getting it. Suppressive or prophylactic antibiotics in these cases are an absolute last resort when all other options have been exhausted or are contraindicated. reconsider using antibiotics for this reason and question why and if we can stop, since this is likely leading to patient harm, drug resistance without much patient benefit. This requires a difficult case-by-case assessment. And with that, we have finished all of our modules for our basic infectious disease assessment and management. Key learning points for this session are listed. I encourage you as well to re-review these cases to get practice with applying a systematic process to infectious diseases cases. In real life, when you are faced with a real patient, sometimes it's easy to get overwhelmed, and the amount of information you have to integrate can make it difficult to know where to start. With this systematic approach, you will be armed to identify the infection appropriately or exclude it, and create a justifiable antibiotic plan that does not require you to memorize recommendations from tertiary references. Thank you for watching, and good luck with your training.